Hey everyone, Chris here from MedPrep2Go, and welcome to another episode of our USMLE Step 2 Questions podcast. I'll be your host for today, and in this episode, I'll be reading 3 more ophthalmology questions from our online Qbank. And of course, you can read these questions and more at medprep2go.com. So let's get started with question 1, Ophthalmology 7. A 68-year-old man comes to the ophthalmology clinic for a routine follow-up. He has no acute vision changes, but he notes that he sometimes bumps into furniture while walking at night. He has a history of type 2 diabetes mellitus and hypertension. Physical examination reveals an intraocular pressure of 26 millimeters of mercury in the right eye and 27 in the left eye. Fundoscopic examination shows an increased cup-to-disc ratio of 0.7 bilaterally with thinning of the neural rim. Automated visual field testing demonstrates bilateral arcuate scotomas in the peripheral visual fields. The anterior chamber angles are open on gonioscopy. Which of the following is the most appropriate initial pharmacologic therapy for this patient? Is it A, laser trabeculoplasty, B, oral acetazolamide, C, topical latanoprost, D, topical pilocarpine, or E, topical timolol? And the correct answer is C, topical latanoprost. The patient is presenting with chronic open-angle glaucoma, COAG, characterized by elevated intraocular pressure, optic nerve cupping, and peripheral visual field loss, scotomas, in the setting of open anterior chamber angles. Topical prostaglandin analogs, such as latanoprost, are considered first-line pharmacologic therapy for COAG. They work by increasing the drainage of aqueous humor through the uveoscleral pathway. They are preferred due to their once-daily dosing and high efficacy in lowering intraocular pressure with a favorable systemic safety profile. Answer choice A, laser trabeculoplasty, is incorrect. Laser trabeculoplasty is an effective procedure to increase aqueous outflow and is often used in patients who are non-adherent with or intolerant to medical therapy. However, topical medications like prostaglandin analogs are typically initiated first in the management of COAG. The question also specifically asks for pharmacologic therapy. Answer choice B, oral acetazolamide, is incorrect. While carbonic anhydrase inhibitors can lower intraocular pressure by decreasing aqueous humor production, the oral form is generally reserved for acute management of angle closure glaucoma or as adjunctive therapy in refractory cases of COAG due to its significant systemic side effects such as paresthesias and metabolic acidosis. Answer choice D, topical pilocarpine, is incorrect. Pilocarpine is a cholinergic agonist that increases aqueous outflow through the trabecular meshwork. While historically used for COAG, it is rarely used today as a first-line agent because it requires frequent dosing and causes significant side effects including miosis, limiting night vision, and accommodative spasm. Answer choice E, topical timolol, is incorrect. Topical beta blockers like timolol were formerly the first-line treatment for COAG. They work by decreasing aqueous humor production from the ciliary body. While still widely used, they are generally considered second-line or adjunctive to prostaglandin analogs because they are slightly less effective at lowering IOP and carry risk of systemic side effects such as bradycardia and bronchospasm. Key learning point. Topical prostaglandin analogs such as latanoprost and bimatoprost are the first-line pharmacologic treatment for chronic open-angle glaucoma. They function by increasing uveoscleral outflow and are preferred for their high efficacy and once-daily dosing. Question 2, Ophthalmology 8. A 74-year-old woman is brought to the emergency department due to the sudden onset of painless vision loss in her right eye that began 30 minutes ago. She has a history of atrial fibrillation and carotid artery disease. On physical examination, her visual acuity in the right eye is limited to hand motion only. An afferent pupillary defect is present on the right. Fundoscopic examination of the right eye shows a pale opaque retina with a prominent cherry red spot in the fovea. There is noticeable segmentation of blood flow in the retinal arterioles. Which of the following is the most appropriate next step in the management of this patient? Is it A, emergent ocular massage, B, intravenous methylprednisolone, C, intravitreal ranibizumab, D, laser panretinal photocoagulation, or E, topical timolol? And the correct answer is A, emergent ocular massage. This patient is presenting with a central retinal artery occlusion. CRAO, an ophthalmologic emergency analogous to an ischemic stroke of the eye. The classic presentation is sudden, painless, profound monocular vision loss with a cherry red spot on fundoscopy, which is caused by the contrast between the pale ischemic retina and the preserved choroidal circulation under the thin fovea. Management must be immediate to attempt to dislodge the embolus and restore blood flow. Emergent ocular massage is a standard initial maneuver to fluctuate intraocular pressure and encourage the embolus to move more distally into the arterial tree. Other immediate interventions include high-flow oxygen and medications to lower intraocular pressure. Interchoice B, intravenous methylprednisolone, is incorrect. High-dose systemic corticosteroids are the treatment of choice for giant cell arteritis, GCA, which can cause vision loss via anterior ischemic optic neuropathy. While GCA can cause CRAO, it usually presents with systemic symptoms such as headache and jaw claudication and an elevated erythrocyte sedimentation rate, ESR, and C-react protein, CRP. In this patient with cardiovascular risk factors and cherry red spot morphology, embolic CRAO is more likely and mechanical displacement is the priority. Interchoice C, intravitreal ranibizumab, is incorrect. Ranibizumab is a vascular endothelial growth factor VEGF inhibitor used to treat wet age-related macular degeneration or macular edema secondary to retinal vein occlusion. It has no role in the acute management of central retinal artery occlusion. Interchoice D, laser panretinal photocoagulation, is incorrect. This procedure is used to treat proliferative diabetic retinopathy or the neovascular complications following a retinal vein occlusion. It is not used in the acute phase of an arterial occlusion. Interchoice E, topical timolol, is incorrect. While lowering intraocular pressure is a goal of treating CRAO to increase the pressure gradient and encourage arterial flow, topical timolol alone is insufficient. While it may be used as an adjunct, the physical maneuver of ocular massage or more aggressive IOP lowering measures, like anterior chamber paracentesis, are prioritized in the hyperacute setting to physically move the obstruction. Key learning point: central retinal artery occlusion is an ocular emergency presenting with sudden, painless vision loss and a cherry red spot on fundoscopy. Immediate management focuses on dislodging the embolus via ocular massage and rapidly lowering intraocular pressure to restore retinal perfusion. Question 3, Ophthalmology 9. A 25-year-old construction worker comes to the emergency department because of a 4-hour history of severe pain, tearing, and a gritty sensation in his right eye. He reports that the symptoms began while he was using a high-speed metal grinder without eye protection. He has significant photophobia and difficulty keeping the eye open. He does not wear contact lenses. Physical examination shows significant conjunctival infection of the right eye. Visual acuity is 20/20 in both eyes. The pupils are equal, round, and reactive to light. Fluorescein staining is performed and reveals a thin, linear area of yellow-green uptake on the cornea. Eversion of the eyelid shows no foreign body, and there is no evidence of globe penetration or intraocular foreign body. Which of the following is the most appropriate next step in the management of this patient? Is it A, ciprofloxacin ophthalmic drops, B, erythromycin ophthalmic ointment, C, ketorolac ophthalmic drops, D, pressure patching, or E, topical anesthetic drops? And the correct answer is B, erythromycin ophthalmic ointment. This patient has a simple corneal abrasion, likely caused by a small piece of debris. In a patient who does not wear contact lenses, the most appropriate management for a small, non-infected corneal abrasion is a topical antibiotic ointment such as erythromycin. This provides both prophylaxis against infection and lubrication to reduce the friction of the eyelid over the damaged epithelium, which helps with pain and promotes healing. Most simple abrasions heal within 24 to 48 hours. Answer choice A, ciprofloxacin ophthalmic drops, is incorrect. Ciprofloxacin or other fluoroquinolones are the preferred agents for patients who wear contact lenses. This is because contact lens wearers are at high risk for Pseudomonas aeruginosus keratitis, which requires specific anti-pseudomonal coverage. In a non-contact lens wearer like this construction worker, erythromycin is sufficient and more cost-effective. Answer choice C, ketorolac ophthalmic drops, is incorrect. While topical nonsteroidal anti-inflammatory drugs like ketorolac can provide analgesia for corneal abrasions, they are generally used as adjunctive therapy rather than the primary next step. Lubricating antibiotic ointment is the standard first-line treatment for both protection and symptom relief. Answer choice D, pressure patching, is incorrect. Pressure patching was historically used to reduce pain by preventing eyelid movement. However, it is no longer recommended because it does not speed healing and may actually increase the risk of infection by creating a warm, moist environment conducive to bacterial growth. It is strictly contraindicated if there is any suspicion of a contaminated wound or fungal/pseudomonal infection. And answer choice E, topical anesthetic drops, is incorrect. While topical anesthetics such as proparacaine are used in the office to facilitate a thorough eye examination, they should never be prescribed for home use. Repeated use of topical anesthetics is toxic to the corneal epithelium, can mask worsening symptoms, and inhibits the normal healing process. Key learning point: the management of corneal abrasion involves topical antibiotic prophylaxis and pain control. For most patients, a lubricating ointment like erythromycin is preferred. However, for patients who wear contact lenses, topical fluoroquinolones should be used to provide coverage against Pseudomonas aeruginosa. And that will conclude this episode of our USMLE Step 2 Questions podcast. I hope you enjoyed it and found the information useful. Please be sure to follow us at MedPrep2Go on LinkedIn, Facebook, Instagram, and YouTube to stay up to date with our content. You can learn more and read other Step 2 questions at medprep2go.com. Happy studying!